Hi everyone, welcome to our chat this evening. I'm Nikki and we have very fortunate tonight to have Kristin back with us. She's been on a couple of times before with Hannah, and tonight we're going to be talking about monoclonal antibody therapy. You may know or may have heard of something called anti-nerve growth factor. So we're going to have a little chat about that, but we'll get to that eventually. We're just going to go through a few other things to help it make sense first. And if you do have any questions, please do pop them along the side there and we'll try and get to them at some point. So Kristin, if you haven't seen her before, she is a small animal vet and she works with orthopedic cases and pain management and rehabilitation based in Seattle. She also is involved with a kind of similar thing to CAM called CARE, which is the Canine Arthritis Resources and Education group. So very on a par with Hannah with all her feelings towards this kind of thing. So I'm just going to pass over to Kristin for her to introduce herself, and then we'll start chatting through what we've planned to talk about.
Sure. Thanks, Nikki. And hi, everybody out there. You did a great job summarizing. So yeah, I'm a small animal surgeon and rehab specialist, and I live and practice in Seattle, Washington. And within kind of the rehab orthopedic surgery world, the kind of bridge between the two and where my passion lies, just like Hannah, is arthritis. And that's come from working with the cases and then also my own dogs over the years of having to figure out all the different things that we can do to keep them happy and healthy. And and so out of that CARE, Canine Arthritis Resources and Education, that came about a few years ago. Again, similar to CAM, just trying to spread the word and the education and knowledge to as many people as we can to help as many dogs as we can out there that are affected by OA.
Yeah. So many of them, so many of them. And I think, we actually had a speaker the other week. We were talking about tips at the end of our chat. And he said one of the biggest tips that he would give people is to get involved in a community with other people that really care and are as passionate about arthritis as you are. So, we have those on both sides of the ocean there, don't we? So we're going to start talking then about pain initially, and I was just hoping you could sort of give us a nice easy-ish summary of the pain pathway so that we can kind of understand where some of the therapies that we currently use and maybe ones that we're going to get quite soon, where they may come into play.
Absolutely. So the pain pathway, so I think actually just to start and say, pain in general is it's designed as a protective mechanism for any organism, from an amoeba up to a human. There are receptors on the outside of an amoeba, and on any living being, there are these receptors that can feel something that's bad. And the job of these receptors is to transmit that signal up to the brain that says, danger, don't keep doing the thing that you're going to do. And then the brain processes that and it has a reaction. So for example, actually, there's a really cool little study that they did with amoebas. They put them in a petri dish and dropped in like an acid. And the amoebas had these sensors on the outside that said, oh, danger, and they turned away from where that acid was. The same thing happens with people. So if we touch a hot stove, there's going to be receptors in our fingertips that instantly communicate to our brain that's hot, and then we have this reflex and we pull back. And so that's pain on the most basic level from a protective mechanism.
Yeah.
And this pain pathway starts with those receptors, those nerve endings, whether they're in your fingertips or whether they're in the joint. They are there to try and communicate to the brain what's going on. And sometimes it's good stuff. Sometimes it's, working on balance, or sometimes it's, just saying, hey, I'm bending my joint right now. But the pain pathway are these nerve endings that say something bad is going on, do something about it. And this connection goes from what we call the periphery, which is really anything outside of the spinal cord, up to the spinal cord. There are some regulators in the spinal cord that can change the signal that's coming from the outside and then up to the brain. And then the brain processes it, and then the reaction that happens going back to the periphery.
Yeah, it's quite a good point, actually, because I think a lot of the time people say pain and we always think of it as an unpleasant thing, and it is unpleasant, but like you say, it can be protective, and it's actually a really important, it is important, and you don't want to get rid of all of that, because otherwise you would burn your hand, or you would overextend your leg, or something like that, wouldn't you? So it is really important. So when you're talking about the receptors and the periphery, is there, how does, a little bit more detail about that? There are things that are released, aren't there, that may then help us understand what we're going to talk about.
So I'm not sure if you can see this. I printed this out.
Oh, amazing.
So that's how detailed it really gets.
That's like, so detailed.
Yeah, we're not going to go through all it, because I look at I look at this and it's really scary. But the point is that there are cells that release these, we'll call inflammatory products. There's a lot of different ones. So there are all these different little things that get released. And then this is the nerve ending, and all of these, like backwards, all of these things here are the receptors. And so the receptors are on the end of the nerve ending, and there's a variety of all these little balls, these little bad guy inflammatory things. So for example, prostaglandin E, PGE, is one of the kind of classic inflammatory products. We also have NGF, or nerve growth factor, which is what we'll talk more about. But these are two inflammatory mediators that have different receptors on the end of the nerve, and they kind of communicate in different ways. But they're both saying, hey, pain is happening. And, so I started off by saying pain has a protective role to start, but if it goes unchecked, meaning that pain goes on too long, the nervous system literally changes so that it's easier to feel pain. So something that otherwise wasn't painful, so just moving your joints, just standing, just moving around, that shouldn't be painful. Now we have more of these little bad guy inflammatory products being released. The nerve endings are sensitized, meaning they can feel things that otherwise they wouldn't have before. And then we get into this cycle of this chronic pain, which is what happens with arthritis.
And with those things like the prostaglandin and the nerve growth factor, would you say it's quite individual per dog or per person as to how much of each one would cause a pain? Like, it's not like nerve growth factor causes so much more pain than prostaglandin. Are they equal? How does it work?
Yeah, I mean, I think that's a great question. I think the perception of pain, like what you think of pain, is a very, very individual process. It's an individual emotion, and that's going to be different for every dog. But the amount of what each one does it's slightly different. So if we just compare prostaglandin to NGF, I don't know if we can say one causes more or less pain, but they do a little bit different. So the prostaglandin it sensitizes that nerve ending, meaning it makes that nerve more likely to feel bad stuff. NGF does the same thing, but it also does 3 or 4 other bad things. So it will literally tell the nerve to start secreting more inflammatory products. So it has this like feedback loop. The NGF will also bind on other inflammatory cells and create more prostaglandin release and more NGF release. And it's that the change that it has to the nervous system is kind of the part that makes it a little bit more unique, that it's not just sensitizing the nerves, it's literally changing the shape and the look of that nerve to make it more reactive.
Yeah. Okay. Yeah. I think we'll come back to that actually. But I think, one of the reasons for sort of talking about prostaglandin is because we were hoping to just have a little review of why or of what we currently have available to us. And we've spoken at length, and we've had many Facebook Lives on using what we call non-steroidal anti-inflammatory drugs. And they are still currently the best, I believe, I think we all believe that they are the most effective pain relief medication that we currently have on offer to us, isn't it?
I totally agree. Absolutely agree.
Yeah.
And honestly, I don't think that they're ever going to go away.
No.
No matter what we get, I can't imagine a world where we're not still using anti-inflammatories because they are still so effective.
Yeah. So how do they, can you just give us a brief summary of how the non-steroidals work? And we have the newish drug, the Piprant and non-steroidal, the anti-inflammatory, and then we have our older ones, and they both work in a slightly different way. So if we can just sort of summarize those two, and then we can talk more about the nerve growth factor.
So if we think of this prostaglandin, and technically it's prostaglandin E, and we think of that as kind of, it's not this simple, but we think of that as the bad guy. That's the anti-inflammatory product. We get prostaglandin through breakdown of other substances, and that breakdown process is performed by an enzyme called COX-2, usually COX-1, COX-2. It's cyclooxygenase. And so that COX enzyme is what takes one molecule and makes it into prostaglandin. And our non-steroidal anti-inflammatories traditionally block that COX enzyme and prevent the production of prostaglandin. That's a very simplified way because it's not quite as black and white as that, but in general, it prevents the production of prostaglandin. And by doing that, by preventing that production, we now don't have that prostaglandin to bind to the nerve ending receptors and cause that sensitization and cause that inflammation, that redness, that heat, that swelling, the pain that we're aware of.
Yeah. So there's plenty of those in human world as well, aren't there?
So ibuprofen or aspirin is a version of that. And then in animals, it's going to be our carprofen or Rimadyl or meloxicam. Those
and they work really well, and they have done for a long time, and they will continue to do so. And they do have potential, not risks, but sort of side effects, don't they? And that maybe there may be some animals, some dogs that they are not suited to. And so we look for other options. So can we just go through maybe why we wouldn't use them? About maybe, again, prostaglandins, they're kind of the good bad guys, but they can also be the good guys, or not. The COX enzyme can also be a good guy.
Exactly. So if we then dive deeper into this prostaglandin, there's technically 5 different types of prostaglandin, or 4 prostaglandins in one other molecule called thromboxane, and then at least 2 types of COX enzyme. And that prostaglandin E that we're most concerned about, while it can be a bad guy in inflammation and pain, it also regulates blood flow to the stomach, and it regulates blood flow to the kidneys. So if we never want to completely wipe it out, because if you do that, then you're going to have some issues with the stomach and kidney in particular. So even when we use our non-steroidals, they're not completely eliminating the prostaglandin. But there may be some dogs that are more sensitive to the non-steroidal anti-inflammatories. The most common side effect is going to be related to the stomach. So it's going to be going off their food. It's going to be vomiting, diarrhea. And if that happens, you need to stop it right away and talk to your veterinarian. We also worry about the kidney. So if dogs have some underlying kidney issues, and they may not be the right choice to put on some of the traditional non-steroidal anti-inflammatories, NSAIDs. Or, we worry if we're doing anesthesia and their blood pressure might drop. We may not want to give it during that time, because again, that prostaglandin regulates the blood flow in the kidney, which can be affected by blood pressure. The other organ that we get worried about is the liver. The liver has to process any drug you give. And this is where I know Hannah feels the same way. Like people will get really anti-NSAID and give all sorts of other herbs and all sorts of other like concoctions, thinking that they're safer. But in reality, they are all still processed by the liver. And we don't have any research to show what they're doing. So we get worried if the dogs have a bad liver, the NSAIDs can make the liver work a little bit harder, and it can expose some bad things. But in general, it's really, really, really rare for an NSAID to cause a liver issue. If it does, it's something very unique to that dog, and that molecule, the liver says, I can't process this, and has a bit of a freak out.
Which is why we always recommend doing bloods before you start medications, and review bloods just to make sure that we're doing the right thing. It makes perfect sense when you explain it like that. And then we have the more recent pip-prant drug, Galliprant, which is what probably a lot of people will know it as and may have experience of that now. And that works in a slightly different way, doesn't it?
Slightly different, yeah. So rather than blocking the production of the prostaglandin, it blocks one of the receptors. So if we go back to this prostaglandin molecule, the PGE, it has 4 receptors that help it do its job. The receptors are in the joint, they're on the kidney, they're in the stomach. And Galliprant works by blocking the one receptor that's most important in transmitting that pain. So by leaving these 3 other receptors and leaving the prostaglandin itself, it kind of allows that prostaglandin to still do the good stuff, but block the transmission of pain. And so I don't know about you, but in my practice, I've definitely seen dogs that weren't able to take some of the other medications, and they're able to take Galliprant.
Yeah. And then equally you get the odd 1 or 2 that still doesn't agree with them, and then we have to use something else, which is fine, but it's always worth trying, isn't it? So that's just a bit of a review of what we commonly use, and anyone with an arthritic dog that is on pain medication has either probably tried one of those or is still on one of them, and they are fantastic. And now we're going to just move a little bit on to a therapy that we currently don't have, but is hopefully coming soon. But I just, before we talk about that, this is one that affects the other substance you're talking about, or the other mediator, I don't know exactly what you call it, but the nerve growth factor. So can we just talk a little bit more about nerve growth factor and why it's there, where it comes from? Is it just produced when you're getting an inflammatory reaction? What happens?
So nerve growth factor, as it sounds, it's a growth factor. So we've got a number of different growth factors in the body, but growth means it's kind of stimulating the tissue to grow. And nerve growth factor is really important in in a fetus, or like a prenatal development of nerves. So it really is helping those nerves grow. And in the kind of immediate postnatal period, it's still helping the nervous system develop. Okay, so that's all very important, very good stuff. In the adult, it turns out that the main role of nerve growth factor, or NGF, it turns out that the main role switches over to a signaling molecule for pain. So again, there's going to be times where it potentially helps damaged nerves grow or regenerate. But much more often what it's doing is being a signaling molecule that's released when there's tissue injury or damage or inflammation. And it's now sending that signal to the brain that pain is happening. Okay.
And they are, so nerve growth factor is basically, it's released anywhere where there are nerves then, I guess.
Well, it's released anywhere there's nerves, but it's actually released from all sorts of tissue. So mast cells, which we're all familiar with, like mast cell tumors. So mast cells are actually found in joints, and they are a very potent releaser of nerve growth factor. Chondrocytes, fat cells, muscle cells, immune cells, so our macrophages and neutrophils and lymphocytes, all of these guys actually can release this nerve growth factor.
Okay.
And many of them actually have receptors for nerve growth factor. So in theory, one mast cell can release nerve growth factor, which can influence another mast cell to release more nerve growth factor, and this whole cycle happens.
So it spirals out of control.
Yeah. And then the other things that get released from a mast cell would be like histamine and bradykinin and prostaglandin and all of these other inflammatory soup stuff. But then the important thing is where there's also a nerve nearby, the nerve growth factor binds to the same type of receptor on the nerve ending. And that's where the signal now starts getting to the brain, and the nerve itself literally starts changing such that it contributes to inflammation
So it
and
produces more again.
produces more.
Takes up more.
Yep. And it makes it much easier. So something that otherwise wouldn't have been painful, now this nerve is kind of on hyper alert that anything that touches it, it's going to be sending bad signals.
So even if you have a dog that is currently on an NSAID, it's still potentially it's still getting pain from that process that you've just described.
Absolutely. Yeah. Yeah. And I think all of us have seen that, that the NSAIDs are great, but there almost always comes a time where you have to add something else in. And just to cover that other types of pain.
Yeah. So nerve growth factor is there. You can't get rid of it, or can you? So let's now talk about monoclonal antibodies and what they are, and then we'll try and glue the two things together and explain that, if that's okay.
So antibodies, I think in this day and age, everybody now is aware that antibodies are a good thing, right? So you get COVID, your body naturally produces antibodies to fight that virus. Right? So antibodies are something that your white blood cells make, and there's all these different types of antibodies. When we say monoclonal, it means that it's a type of antibody that recognizes one receptor. So if we think about COVID, and everybody's seen the little spike proteins, and we know that we're trying to build antibodies to glob onto those spike proteins. So the antibodies can then block the action of whatever they're fitting onto. So with antibody therapy, we can give an antibody that recognizes a target, and it works like kind of a lock and key, and it globs onto that target. So for nerve growth factor, there's we can make an antibody. You can literally kind of produce it that is specific for a dog, or specific for a cat, or specific for a human. And that antibody then recognizes the nerve growth factor, it binds to it, and it prevents the nerve growth factor from binding to the receptor. So essentially it neutralizes the nerve growth factor. And it's not an all or none. It doesn't neutralize all of the nerve growth factor in the body. It just kind of dampens it down.
Okay. So, and it's not specifically, if you give it, it's not specifically going to the nerve growth factor in your joints. It's just like you say, damping down the whole overall effect.
Yes, but there's we know that there's elevated nerve growth factor in joints that are arthritic. So it's going to, it gets spread throughout the body. And it will have probably more effect in the joint because there's more nerve growth factor there than there should be. So it does kind of dampen it down.
Okay, so this has been developed for other conditions as well. I believe it's the one that we use a lot. Again, people may know about it, but there's a really lovely antibody we use for skins now, and that it is based on a similar process.
So cytopoint.
Cytopoint. So this isn't a specific technique or therapy just for arthritis, is it? It's been developed for lots of different things, and we're just lucky that there's something that they could develop it for nerve growth factor that was found to be a part of the pain pathway.
Exactly.
So when we talk about nerve growth factor, and it's something that people are going to be more familiar with, so they've now discovered and produced this specific antibody to nerve growth factor, and you just mentioned there that it has to be species specific as well. So you can't just have one and give it to everybody. It's not going to work that way. And so it has to be your canine one, feline one, whatever you're going to use it for. And that then means that it has been tested and studies have been done in all the species that they're trying to develop it for. So would you be able to, you were very kind to send over lots of studies for me to read, and I found them really interesting. I don't know if you can kind of give us your overview of the canine ones in particular, or maybe the human ones, because I think were the human ones done first and then the canine ones?
Yes. Yeah. So initially, like any sort of pharmaceutical development, they usually start with rodents. So they were kind of rat and mouse, studies, and then onto the human side. And this was kind of in the, at least 10 years ago, if not longer than that. Yeah, definitely 15, 20 years ago, started studies looking at anti-nerve growth factor in humans. And to your point, that right now in the United States, there's at least 60 different monoclonal antibody therapies for different types of cancer, for immune-mediated arthritis. And so they said, let's look at an antibody for nerve growth factor. And so there were at least 3 different antibodies. They were all targeted nerve growth factor, but they had a little bit difference. They were being developed by 3 different companies. And they started enrolling a number of human patients in it. And they were definitely seeing clinical results. They were seeing a lot of improvement, most specifically, generally humans with knee and hip arthritis. And they were definitely seeing improvement. But after a few years, there became this kind of concern or signal that maybe there was a subset of people that their arthritis was all of a sudden progressing much faster than it would have without the antibody therapy. And so in the US, they put a pause on all of the research for a couple years to see, is this really a concern? Are these people having more damage than it's worth? And they went through a couple years worth of kind of really digging in, and the end result was maybe the case selection is important. The higher the dose you give, the more risk there may be for these side effects. Okay. But and potentially combining it with an anti-inflammatory may be wrong. But the end result was that the potential benefit way outweighed the risks. And so they continued with the development. And so on the human side, it's still not available for humans anywhere in the world. I don't know how far off it is, but I think it's probably not too far off. They've completed all of what's called the phase 3 clinical trials, so the big clinical trials. They've finished those, and I think they're in the process of getting things approved. So then the dog and cat ones, yes, there are very specific antibodies. There's a cat one, there's a dog one. The studies that have been published, the ones that are published, are still pretty small pilot studies. There has been research, much, much bigger research that the companies have done that we haven't seen. I haven't seen. They're not publicly available, but they have been submitted to the regulatory agencies in Europe and UK and the US. And at least in Europe, the regulatory agencies have given it like 2 thumbs up and said, everything's good to go. So I mean, we can even say the names. So Librela and Silencia. So Librela is the dog version and Silencia is the cat version. Those are the products that have almost gotten to market in Europe. In the US, we're a little bit further behind. I honestly don't know why. I think that COVID actually played into some of the setbacks, but the studies that went into the dog and cat version, again, they showed positive results, similar to, or if not better than traditional NSAIDs. And cats,
is really exciting.
Yeah, I mean, we talk about canine arthritis, but cats in particular, it's been really, really, really tough to come up with medications that treat pain in cats. So it's really exciting to get this for cats. Yeah,
it's so exciting on so many levels. Number one, the fact that it's got a name means it's definitely going to happen. It's coming. And like you know, in some cases, it seems like it may be better than NSAIDs. It's still, I guess we will find out. And there's just so much to learn about it. Can we just go a little bit back into the studies with the dogs, just so that we can understand what kind of things were they looking for and looking at when they were assessing the pain levels, and whether it kind of worked or didn't?
So one of the things that they really care about now, they meaning the investigators and then also the regulatory agencies, are the client assessments. So basically the pet owner's assessment of how your pet is doing. So one of the most common ones that's used now is called the Canine Brief Pain Inventory, and it's a questionnaire that the pet owner will fill out before starting the medication and then after. And then generally in these studies, you as the pet owner, you don't know whether your dog's getting the treatment or they're getting the placebo.
Yeah.
And so you fill out the questionnaire before and afterwards, and then, then statistics are done, and then kind of figure out what the success rate is. And studying pain in general is really hard because there's a 50% placebo rate, meaning that if your dog got a placebo, well, let's say 50% of the people whose dog got a placebo will say their dog got better.
Yeah.
So when you're designing a study, you have to account for that. So the treatment has to be even so much better. But I think what's good about it is what we know from arthritis is, we can't just look at how the dog reacts if the vet does range of motion of the joint. So that's important for sure. But what's so important is, how does that dog act at home? Are they able to climb the stairs? Are they able to go for the walk like they used to? Do they seem like they're painful or sad or dull or depressed? And so that taking into account the client perception of their pet's mobility and function is really important. So that the Librela studies and the Silencia studies both found that clients were able to detect improvement in their dogs. Placebo.
Yeah, I have to say, when I was reading through those, and I thought, the fact that it said, you read through some studies and it's very much like, so we had them here and we measured this, and this, but those studies were client based, weren't they? So that it was what was feeding back from the home, from the lifestyles and that kind of thing. I just thought that was really, it makes me believe more in it as a vet, when I'm getting the owner's perception as well as facts and figures and measurements and that kind of thing.
They still do those things, and they still do definitely take into account the veterinary assessment.
Yeah.
But I think we know now that it's the pet owners are much, much, much better at identifying their own dog's chronic pain than we are.
Yeah. The signs of pain are just, there's like millions of them, aren't there? And there's some that as a vet you can obviously see them, but a lot of it is what they're doing at home, because they always react differently when they're in the vets with you. So we do rely quite heavily on owner information as well. So with the nerve growth factor then, with the anti-nerve growth factor therapy, how is that going to work? How do we anticipate that's going to be given? What is it? A tablet? Is it an injection?
So I'll preface this by saying I don't know what the product label is going to say.
Okay.
My understanding is it's going to be an injection, and a subcutaneous injection that the veterinarian will give. My understanding, and you can't hold this to me because I don't know for sure, but my understanding is it's going to be once a month. So you'd bring your pet into the vet. They'd get a pretty easy shot. So it's not in the muscle, it's not in the vein, it's just under the skin.
Just like where you give vaccines and most of the injections we give.
Once a month. And some of the studies haven't gone out years and years and years, but they've gone out several months, and it does seem like that it has a pretty robust duration of action. What I don't know is, if you give it for 3 months, can you take 6 months off, or do you have to? I don't know. I mean, I've got a lot of questions too.
Yeah. And would there be any times, because we're saying earlier that nerve growth factor actually does have, especially early on in life, it does have a real benefit. So I'm guessing that we wouldn't want to be using it in really, or hopefully we wouldn't need to, but we wouldn't want to be using it in really young animals. Or would there be times when you thought, actually, like, this dog has spinal issues, we don't really want to be using this? Do you anticipate, what do you think about using it in potentially for good reason?
I have all of these same questions too, and again, I don't know anything that's from the manufacturer, what guidelines they're going to give us, but for sure in a young animal. Now, young, I don't know if it's 9 months old, are their nerves fully grown? I don't know, but definitely in a neonatal animal, one that's, I don't know. I'm literally just guessing here, but 6 months or younger, my guess would be we're probably not going to want to use it. Probably not in a pregnant animal. That's for sure going to be, my guess would be a no-no.
Sure, that makes sense.
There's conditions like neuropathies, like diabetic neuropathy, or I think about like a brachial plexus avulsion or nerve injuries. I don't know. You know, there are studies when they first identified nerve growth factor, people started looking at it for a positive, to use it to help stimulate neuroregeneration, especially in the brain. So they've looked at it for like Alzheimer's disease, giving nerve growth factor.
Yeah.
I should actually really importantly say that when we give the monoclonal antibody, it doesn't get to the brain. Like it doesn't cross what's called the blood-brain barrier. So there were some studies looking at giving it to try and help protect nerves or help rebuild nerves. And what they found was that, you know, overwhelmingly the side effect was increasing pain. So people were, when they gave it, people were too painful.
Okay.
So to your question of, are there going to be conditions that we don't use it in? My thought is that there probably will be. I don't know yet what those will be. I think there's going to be a lot of other types of pain that we'll use it for. So it's going to be labeled for arthritis pain, but there's research in bone cancer, and there's research. This is the part that I'm really excited about, and you know, it'll be technically off label, but stuff like stomatitis and cystitis. And so in humans, they've looked at cystitis, they've looked at prostatitis, they've looked at other visceral types of pain. Or abdominal pain, and found some potential benefits there. So,
oh wow, yeah, that would be. I mean, stomatitis in cats and that kind of thing, which would be amazing. And do we know much about potential adverse side effects to the injection then?
So in dogs and cats, they've been very minimal. I think in cats, they reported that some of them like scratched a little bit more at the injection site, which may or may not be related to the actual injection. So from my understanding, my reading, that there's been really minimal side effects. And one of the cool things about antibody is that it's not the way that it's broken down and the way that it's metabolized is very, very different than our anti-inflammatory, our non-steroidals, any of our traditional drugs. And because of that, it has virtually no effect on the kidney, has no effect on the stomach. So it doesn't have anything to do with blood flow to the stomach, doesn't have anything to do with blood flow to the kidney. The molecule itself is actually too big to be filtered by the kidney. So it's really going to have to do with it. Same thing kind of with the liver, the way that it's broken down and processed, it's just kind of recycled into smaller little pieces of proteins that just get recycled by the body. So the side effect profile should probably be better than what we're used to with our current drugs.
Much safer. And that leads me on to another question then, because we're targeting different areas and different inflammatory mediators, is there potential to use the two together, the anti-nerve growth factor and the non-steroidals?
Again, I think yes. I think there's going to be some guidelines because of what they saw in humans, because there was maybe this increased risk of progressive arthritis when you combine the two. My guess is that you will be able to combine the two, but maybe not forever long term. I think that it will take, I don't know this for sure, but I think you give a carprofen or a meloxicam dose now, and it has pretty instant effect, right? You have to take an ibuprofen. I don't think that the Librela, let's say, I don't think that's going to have an instant effect. So there may be a period of time that you want to keep them on the anti-inflammatories while the Librela is starting to take effect, and then maybe you don't need it anymore. And then they just move on. So.
Yeah, because initially, a lot of the cases that we're going to use this in are cases that will already be on either non-steroidal or a combination of pain relief. So I guess not going to be an instant impact. Then you're not going to change anything immediately, and then just sort of trial to tone down what you're using.
That's what I would do.
So it wouldn't be just not going to turn up at your vets and say, okay, here's everything you've ever given me, I just want the injection. That's not how it's going to work. But yeah, it's a really exciting development. And I'm just there's a couple of questions regarding this, actually, if you don't mind having a look at that. So first of all, just popping back, I don't know if I wasn't very clear with this, but Luke's just written, just going back a little bit, is Galaprant still classified as an NSAID, or does it stand alone as a Piprant? Kind of both.
Yeah, it's kind of, so technically it is so Galaprant is a non-steroidal anti-inflammatory. So technically it's an NSAID, but this new class of drugs called Piprants, Piprants are a new class of drug that mean that they block the prostaglandin receptor. So there's other drugs out there that are in the Piprant class. So technically it's a non-steroidal anti-inflammatory, but it's a non-COX inhibiting NSAID.
Non-steroidal.
Yeah.
I hope that clears that up, Luke. Yeah. Just another question here. I think this isn't an NSAID, this is pregabalin, but my dog, from Anne, my dog cannot have NSAID, so she's on pregabalin. Can this be combined with this new monoclonal antibody, or will it replace it? I think sort of just covered that, in that you probably wouldn't initially take your dog off of it, even though pregabalin is, I don't know, what do you think?
I would say if it's a tough one. My guess is it's going to be a transition off of pregabalin to the monoclonal. It may not be, because they work in different mechanisms. It may be one that you keep them on together. I haven't seen any studies where they have been used concurrently. No. And I doubt that there's going to be any of those studies available right when it comes available. So like other things, I mean, nobody told us it was okay to use an NSAID and pregabalin together. Yeah. We figured it out, right? So I wish I had a clear answer. I think we're just going to have a lot to learn when this becomes available.
Yeah. And when it is, the vets are going to be onto the company and talking to them. They're going to be bombarded with questions on a daily basis, aren't they, about what we can and can't do. So if there's any queries, the best place to go to initially is your vet. But as you can see right now, they're not going to know anything until the drug is actually released and on the market. So bear with them, and all the answers will hopefully become clear as time goes on. We've got Luke. He's already loving the name here. If Librela only works on NGF and doesn't target other types of inflammation, it will be used alongside NSAIDs. Kind of said initially yes. And if it works on nerve pain situations, will it make things like amantadine, GABA, pregabalin less relevant to OA? What do you think about that? Do you think?
So I do think that yes. I think again, if we go back to this guy, like there's a million things going on. So my impression is that NGF is a really important part of inflammation. It's something called neurogenic inflammation that we didn't really get into the details, but my gut is that there's probably going to be some cases that still benefit from the other one. So amantadine is probably my favorite drug right now. Mechanism action, but I don't know if you're still going to need it. I honestly don't know, because the way that amantadine works is to prevent this central sensitization and wind up. And that's one of the things that Librela is, going to be able to do, is to help prevent that central sensitization. Just a different mechanism to get there. So I don't know.
Yeah, it's interesting, isn't it? Just to see what's going to happen. I mean, hopefully that would be great if you didn't have to use all these other drugs. That would be amazing. If you could just use that. But until it happens, I mean, we might start using it and go, oh, I don't know, I really prefer my non-steroidal over this. We don't know, but it's out there, and theoretically it has more behind it to hopefully be a better pain relief than the non-steroidals.
Hopefully,
I hope so. I'm so excited about it. I was saying to Kristin earlier, like I have this list in my head of clients, like, yep, you're going to get it, you're going to get it. I hope it doesn't run out. I hope it's not like COVID vaccine when it runs out and you're like, no, but I didn't use it on that one. I really needed it for them. Just got another one. Oh, Luke, no, sorry. He's asking, is there a release date? Our pain vet is really interested in it. No, I wish I knew. And Kristin's promised me that she doesn't know either. So
I don't know. I'm checking with your Zoetis rep.
Yeah. Check with them. We will, as soon as we know, we'll be getting it in. A question here from Holly. My Labrador is on Previcox. She recently started panting at night, so I've given her half a tablet more. Did I ought to speak to the vet about increasing dose or changing drug? Would Galaprant be better? Well, I think definitely speak to your vet on that one, and she may be your Labrador might be a really good candidate for this. If it sounds like she probably needs some extra sort of pain relief, but yeah, I would definitely speak to your vet about that one. And a question from Laura here. This is good one actually. Has the research been done on all stages of arthritis, from mild to severe or end stage, and was it more successful at any particular stage? And this is something that I was thinking about, because some of the cases I'm seeing that I'm thinking about using it are cases where things aren't working. The current pain management isn't working as well as it did, say, a year ago, because the arthritis is more advanced. So what's your feelings about that?
Well, I think I have the same question, honestly, because the big studies that went into getting these approved aren't available to us yet. So I haven't seen that research, but my guess, my gut would tell me that it's more for the moderate to severe.
Okay.
I don't know. Yeah.
Yeah.
And they probably had a wide range of cases there. But yeah, that's we still are waiting to get all of that available.
Mm-hmm. So that will become available as soon as it gets released, I guess, won't it? Because then they don't need to keep it hidden anymore. Will it, another Luke is here, will it give the changed nerve a chance to recover, or is it likely to prevent further damage? So when the nerve growth factor's been there, I guess you mean when it's damaged that nerve. My understanding is that it's not going to do that. It's just going to block any further uptake, which then should stop that cycle. Would that be right?
Yeah. Yes. Yeah.
Okay. So yeah, I mean, it's probably not going to, the nerves aren't going to repair necessarily.
Well, the nerve itself, if we're just talking OA, and the fact that if we're saying that there wasn't any actual nerve damage in OA, what it's doing is kind of quieting down the signals that are being sent.
Okay.
And in a sense, it actually may make that nerve potentially shrink down a little bit. It's not necessarily a reparative mechanism. If we have nerve that actually has been damaged or cut, say surgically, that may be an instance where nerve growth factor is actually needed.
Yeah, so we wouldn't use the new drug then. Yeah. So there are always going to be those kind of cases, I think, where you think, well, there's pain and there's a severed nerve, then you've got to kind of weigh up, well, you wouldn't use it.
I think we're going to have to, there's going to be certain cases where we do have to, consider it. Is it the right thing for this patient?
Yeah, definitely. I've got another sort of OA question here, not necessarily to do with this one, from Liz. My 9-year-old collie has severe elbow dysplasia and osteoarthritis down to bone on bone. I'm just going to throw this one in here because I know that you're into elbows. He's had an arthroscopy, which made it worse than ever, and he's had 2 rounds of PRP injections, which helped for a few months' time. What pain management would you give him? He's currently on ONSI, or is there anything he would benefit from? I mean, I guess go back to your vet, but do you have any comments on that?
Well, I think yes, go talk to your vet or talk to someone that can do a specific exam, because technically, like, I don't have a doctor-patient relationship, but what I would say about what I treat elbow conditions, very simple. I have a lot of patients just like your dog, and I'm sorry. Elbows are really tough, really, really tough, and even with arthroscopy, we know that long-term it's going to need more. So what I do with my patients, and again, I'm in the US, so I have a little bit different stuff, but which you guys have Cartrophin. So I would use that. I would use fish oils. I would probably use amantadine. And then first and foremost, make sure your dog's not overweight, and talk to your vet about appropriate diet and appropriate exercises and activities, and make sure they're not playing ball and not jumping out of the car and things like that. But definitely, I hate to say, talk to your vet more, but they have to be the one to make those specific recommendations.
Yeah. And you may find again that when this comes out, this might be an option as well. So we've got a question from Barbara. In a dog that has already lost all the cartilage on the inside of the elbow, in my dog's case, could this therapy be too effective at deadening pain, resulting in more damage as your bones rub together? So I guess you're worried more about nerves being already destroyed or being damaged.
Yeah. I think it's the question that kind of goes back to what that maybe they saw on the human side, is that they had this rapid progressive arthritis that set in, and they don't know why. But one theory is that because the joints weren't painful anymore, people were being too active and they were having this worsening of arthritis. But I think when we look at this bone-on-bone pain and we look at chronic arthritis, the number one most important thing is to minimize pain, because if we let this pain go unchecked, we get a whole host of this other type of pain. So things like what we call allodynia, where now other areas of the body are painful just by being pet or just by being touched. And we have spontaneous nerve firing. We have just aching when you're not moving. So my approach is always to tackle the pain with whatever we can. And then it's a little bit of the tough love. It's like, your dog might feel a whole lot better. That doesn't mean they can now go out and play chase, play fetch, and jump out of the car. There still needs to be modified. But we want them to feel better, because we don't want all of those changes in the nervous system to start happening that makes it feel bad all over.
Yeah, and I think most dog owners would completely agree with that, because it is all about quality of life, isn't it?
Yeah,
you want them to be pain-free. That's the most important thing. The mobility may still be restricted, and like you say, you can't do as much, but you just want them to be happy, because that's they are, that's all they want. They just want to eat, they want cuddles, they want affection, and they just don't want to be in pain like all of us. So it's even if it's not necessarily long term the best thing, it's being out of pain is the best thing at that time.
Yes,
definitely. Luke's got one more question. He says, one more NSAID question. Pardel paracetamol is an NSAID, but is usable alongside NSAIDs. Where on the pathway does it work? Are you happy to talk about that?
Well, that's literally like $1 million question, because I don't think anybody exactly knows. There's this thought that there's this COX-3 enzyme that works just in the brain. That's where the acetaminophen or paracetamol works. It's not a very good anti-inflammatory. It's more of just a pure pain reliever. And Nicki, I don't know if you know any better than I do, but
no, I mean, I don't even. I always tell people this isn't anti-inflammatory. This is literally just helping quality of life and making them feel happy, basically. Yeah. And Luke says it does sound fabulously expensive. It does sound fabulously expensive, and nobody knows how much it's going to be, what the doses are. I have
no idea. My guess is it's going to be similar to Cytopoint. And I have no idea. I've never used Cytopoint. It's a derm drug, but my guess is it would be somewhere analogous to that. So it's accessible to most people.
Yeah. I mean, if you think about, if you're not going to be using non-steroidal, maybe, and then it's not going to be that much more than a month's worth of what your non-steroidal would be, probably.
Maybe.
And I'm guessing that the injection wise is going to be weight different per weight, as Cytopoint is.
My guess too. Yeah, but there will be a big dose. Yeah.
So it's not going to be the same, exactly the same dose for every dog, but that will alter the price, obviously. Just a little question there. Was so Kristin was saying about Carprofen, or the Adequan, which is what they use in the US. So not Carprofen. Carprofen is the non-steroidal. Carprofen is the joint injection, Adequan or the Carprofen. So speak to your vet, Holly, about that, and they will know about it. They can certainly line something up for you if you wanted to try that. So just a last couple of things with the new drug. Then we don't know definitely about any adverse side effects. It looks like it's going to be pretty safe. And do you have any potential concerns about it?
I think with any new drug that comes out, I think the concerns are what happens after a dog's been on it for years and years and years. That's probably my biggest question mark. Do I have any concerns about using it day one? Absolutely not. Just like you, I've got a long list of patients that I'm like, as soon as I can get my hands on it, they're going to be getting it, including my own dog.
Really?
Yeah, because I think there is still such a gap in our treatment options that we need something like this.
Yes, definitely.
So I have no hesitation of starting to use it. I have questions about all these great questions that came up of things that we're going to learn with using it with other meds. Do we still need these other medications? I still think there's going to be a multimodal component, but it's going to be figuring out which ones are most needed. And then what happens when dogs and cats are on it for years and years and years?
Yeah. Do you drop the frequency? Do you drop the dose? Do all these things that, well, of course, but there's going to be, with all these drugs, there is some sort of ongoing work the whole time, isn't there? Once they're released, that doesn't mean that that's when it stops. It's still, they're still developing it and changing it. This has happened with lots of drugs before. They're licensed for one particular thing or a particular time period, and it changes as time goes on, doesn't it?
Oh yeah.
So this will happen.
There's going to be ongoing studies. There's going to be ongoing monitoring. So the companies always have a division of their company called pharmacovigilance, which means that any side effects or adverse effects get called in to this pharmacovigilance, and they track it, and they keep track of what's going on. And then also, I think there's going to be a lot of research done to try and answer all of these questions.
Yeah. And then it may even be licensed, like you said, for other conditions where it's going to be.
I know people will start. I will use it for bone cancer pain day one too.
Yeah, that's really limited what you can use at the moment, isn't it? That's that's just heartbreaking, because whatever you throw at them, it's still painful. It's horrible. Yeah, very sad. Well, maybe you'll be able to come back on and talk to us about it once it's been released.
I would love to. Yeah,
and tell us more. That would be really exciting. And hopefully we'll have a little bit of experience of using it as well, as long as it's not too horrendously expensive. So just off topic completely, off this kind of thing, can we just go through, I know Hannah normally does your 10 top tips for arthritic patients. Would you like to just give us 5?
Sure. And these are going to be very similar to what Hannah always says, but I think, number 1 is weight. So make sure that you're not overfeeding. So they have to be the appropriate weight. Number 2 would be keep them moving. So making sure that you know what the right type of activity is, but dogs have to keep moving, going for walks every day, not doing the jumping down or the high impact, but keeping those joints moving. Number 3 is, I know Hannah always talks about this too, but it's the carpets and the yoga mats. It's anything you can rub in the house. Yeah. The other one, which I figured out with my own dog, and I know Hannah talks about this too, is raising the food bowl. So they don't have to put a lot of weight on their front legs if their front legs hurt them, and it helps balance out their spine. And then, number 5, and this is not in any particular order, but just making sure that you're talking to your vet regularly to make sure that the pain management protocol is appropriate and that something doesn't need to be tweaked. So there was a great question about someone increasing the dose of their Previcox. So make sure you're talking to your vet and asking those questions, because sometimes that might not be the right thing to do, and there might be something else that would be better.
Yeah. So don't automatically think that you've already done everything and this is it and you're just going to have to live with it like this. Vets love to talk about this kind of thing. So do get in contact with them, and they will come up with some suggestions. Or the other thing you could do, if you're ever worried, is to just jump on Canine Arthritis Management website and have a look at all the brilliant tips that are there. And there's loads of sort of newsletters and things that you can sign up for, and so you're getting emails to your inbox on a weekly or daily basis, or whatever you choose to sign up for, and that can really help you manage your dog's arthritis alongside the stuff that you're doing with your vets and your therapists as well. So loads of information on the website. Please do come and have a look and support Cam as well. I'm just having a look. Oh, that's really kind, Holly. Holly's just written, I wish either of you were my vets. Well, yes, if you want to move to Seattle or London, that would be fine. So everyone's saying thank you so much. Really interesting. Everyone's really excited about this new therapy, and we will definitely be back on, hopefully with Kristin later in the year when it's available to us. It should be this year, and hopefully it's going to make a world of difference to all of our beautiful dogs.
Yeah,
so thank you so much for joining us, Kristin. It's been really interesting.
It's always my pleasure. It's great to see you guys.
Thank you. Take care, everyone.
Bye.